This is men's hearts also tear apart, a case of spontaneous coronary artery dissection in a male. A little bit about the background of SCAD, spontaneous coronary artery dissection. It's a rare cause of acute coronary syndrome in which an intramural hematoma is formed within a coronary artery. SCAD may cause up to 1% to 4% of ACS cases in general. 80% of cases of SCAD are in women. SCAD is commonly associated with connective tissue disease and arteriopathies, specifically fibromuscular dysplasia. In a study of coronary angiograms in women, 16 out of 177 angiograms in women under the age of 50 were due to SCAD, and 13 of those 16 had fibromuscular dysplasia. In our case, we have a 35-year-old male with no significant past medical history who presents with chest pain, diaphoresis, and shortness of breath during a shower. The patient denied any radiation of the pain or aggravating or alleviating factors. The patient was found to have elevated troponin levels to 0.85 and ST elevation in the precordial anterior and lateral leads on EKG. The patient was taken emergently to the cardiac catheterization lab. Coronary angiography revealed a dissection in the left anterior descending artery. Percutaneous coronary intervention was deferred due to risk of placing a stent in the false lumen of the dissection. The next morning, the patient's chest pain improved. The patient was taken back to the cardiac catheterization lab to evaluate any changes in the dissection, but the dissection was still present within the LAD. Echocardiography showed a reduced ejection fraction of 35 to 40% with increased wall thickness and anteroseptal hypokinesis. A cardiac thallium viability study showed lack of radial tracer uptake at the apex of the left ventricle, which showed non-viable tissue. Both PCI and coronary artery bypass graft were deferred in favor of medical management. The patient was treated with conservative medical management with lisinopril, carvedilol, aspirin, clopidogrel, and atorvastatin, and was promptly discharged home. Here are some figures that depict the case of SCAD in our patient. In figure A, we see an EKG with ST elevation changes in the anterior precordial leads in V1, V2, V3, V4, V5, and V6. In images in B, C, and D, we see images of coronary angiography that show SCAD in the left anterior descending artery. SCAD can be categorized into three types. Type 1 demonstrates the classic appearance of multiple radiolucent lumens in the wall. Type 2 demonstrates diffuse stenosis. Type 3 shows focal stenosis. This patient's coronary angiography shows a second lumen along the length of the LAD, placing it in the type 1 category. There are currently two theories on how SCAD develops. The first theory is that a disruption of the endothelial intimal layer from the inside of the blood vessel allows blood from the lumen to enter the vessel wall, leading to the formation of an intramural hematoma. The second theory suggests bleeding from the outside of the vessel, near the vasa vasorum, which generates an intramural hematoma without disrupting the inner intimal layer. SCAD is a rare condition in men. It is associated more commonly with females, especially during the third trimester of pregnancy or the postpartum period. SCAD is also associated with emotional and physical stressors. In this case, our patient may have experienced physical and emotional stressors that preceded the dissection. He was noted to have been lifting a barbecue grill the day of presentation. The patient was also experiencing emotional stressors regarding his spouse's transportation. Fibromuscular dysplasia is an arteriopathy that is known to be associated with SCAD. On this patient's coronary angiography, no classic signs such as beads on a string of fibromuscular dysplasia were seen. Observational data suggests that the majority of patients with SCAD that are treated with conservative medical management exhibit healing of the dissection within a month. Current data on conservative management of SCAD is still unclear. The rationale for antiplatelet agents is to treat potential thrombus formation within the true lumen. The rationale of beta blockers can be extrapolated from their treatment of aortic dissections. Patients with ongoing ischemia, left main artery dissection, or hemodynamic instability may not be appropriate for conservative treatment, and urgent interventions such as PCI or coronary bypass grafting should be considered.